The Limi Children Hospital is a multi-specialty children hospital with advanced specialty in neonatology, pediatric cardiology, neurology, hematology, nephrology, and vaccination. We provide a variety of clinicians to help deliver the best possible care. Our physicians and nurses have been recognized by a number of independent organizations for overall excellence. We offer consulting services, regular nursery care, premature birth care, and treatment of babies with mild to severe illnesses across our different integrated facilities. Our neonatal intensive care units are well equipped with infant warmers, incubators, phototherapy, monitors, ventilators, and oxygen hood or nasal cannula. As a baby's and family's first pediatric caregiver, our neonatologists often begin their work by providing prenatal consultation to women experiencing preterm labor, carrying multiple babies, or following the finding of a possible congenital malformation that may require special preparation for the birth and coordination of treatment services for the infant. For more information, log on to www.limichildren.org.
Okay, hello dear listeners. You're welcome to our May edition of webinars from Limi Children's Hospital. Before we start, we want to be sure you can hear us. If we are audible, can you just kindly type yes into the chat box? Let's just be sure. Yeah, okay. Okay, thanks a lot. Thanks a lot. So we would start. This is Limi Hospitals, and we are presenting today on behalf of the Limi Children's Hospital. Limi Hospitals is a triad of specialty hospitals with the multi-specialty hospital as a headquarter located in Central Business District, Abuja, where we have all the specialties, including obstetrics, gynecology, surgical specialties, family medicine, ophthalmology, surgery, and all that, with facilities for IVF and other specialized surgical care. And then we have the cardio care multi-specialty hospital, where we are broadcasting from today with facilities for internal medicine, a lot in cardiology with highly skilled staff in interventional cardiology. Actually, the busiest cath lab in Northwest Nigeria, and I think also in Nigeria, a lot of interventional procedures going on. We are presenting today on behalf of the Limi Children's Hospital with our specialties that include neonatology, cardiology, pediatric neurology, hematology, neurodevelopmental pediatrics, and all that. So, but for today, we will start from the neonatal cardiology unit presenting today. Yeah, okay, fine. Yeah, so who are we?
Well, so we are a children's hospital designated specialty hospital for pediatrics, neonatology, as well as adolescent medicine. What is our vision? Our vision is we're driven to become and remain the leading regional world-class patient-centered children facility, working with appropriate innovative technology based on godly principles.
Yeah, so our mission is we want families to be happy because we make the children happy by providing appropriate care. Okay. So healthy families with happy children.
Happy home.
Yeah, so we delve into the topic today, why we are here. So what's our title for today?
Well, we're going to be discussing about respiratory distress in newborns, and we'll be comparing and looking at the pulmonary causes versus the cardiovascular causes.
All right, so I am Dr. Igoche Peter, and with me today is.
I am Dr. Ayomide Oshagbami.
All right, thank you. Yeah, so we have 3 objectives for our presentation today. Yeah, so we want to be able to make sure our participants do the simplest thing, which is to identify neonates with respiratory distress. Yeah,
Also,
very, very simple. Yeah.
we would also want the participants to be aware of how to differentiate respiratory distresses as a result of pulmonary cause as well as cardiac causes.
Yeah, so we must say that this is very challenging because the dichotomy between pulmonary causes and cardiovascular causes could be challenging, but the benefit of presentation today is we would like to differentiate between the two because cardiovascular causes require specialized interventions and the pulmonary ones have their own very different, similar presentations, but we would want to create that dichotomy as much as possible. Yeah.
And then our third objective today will be to identify basic radiologic imaging patterns that can help us differentiate these pathologies.
Yeah, it's okay. So fine, we delve into what is respiratory distress.
Respiratory distress is a clinical sign that simply reflects an increased work of breathing in neonates, since we're focused on neonates in this discussion.
Yeah, so like we'll see in our subsequent slides, that the work of breathing can be, when increased, could manifest with tachypnea, then use of accessory muscles, grunting, cyanosis, desaturation. We'll see that. But we want to say, if we jump from the beginning to the end, we say we've known the definition is when we have constellation of clinical signs that manifest increased work of breathing in the neonates, right? What are the endpoints? The purpose of this discussion is to identify, so we intervene, so there is a resolution of symptoms. Yeah, but if they are not identified on time, there is a spectrum. It progresses from the respiratory distress to respiratory failure, and then to arrest, which could be cardiopulmonary. Remember, the topic is by differentiating between the cardiovascular and pulmonary causes. So we understand that a few people, if not a lot of people, have this difficulty differentiating between respiratory distress and respiratory failure. They are not synonymous at all. Respiratory failure is a worse spectrum of the problem that started with respiratory distress. So we look at rate of breathing, heart rate, we look at effort in the child, we look at appearance. So if we say respiratory rate, for example, a child in respiratory distress would have tachypnea.
Yes.
While if the respiratory rate is counted in the neonate with respiratory failure, is bradypnea. So the bracket is 30 to 60 breath cycles per minute. Yeah. So 30 to 60 cycles per minute, right? So if we have less than 30, we are tending towards respiratory failure, which is bradypnea. Then above 60 is respiratory distress, which is tachypnea. So if we look at the airways, we realize that in respiratory failure, there is an obstruction of the airway. So it's blocked. So there is a failure of exchange because the airway is blocked. Whereas for respiratory distress, it's open, but there is difficulty, right? So the neonate in respiratory distress will have increased effort. Obviously, that is reflected in the definition of respiratory distress. But in respiratory failure, the child has tried, the effort has gone so much, and child like, man, I'm tired. So no effort again, right? So if we auscultate, what do we observe?
Well, for respiratory distress, a lot of times the sounds are clear. So, however, in respiratory failure, you may have abnormal sounds being heard.
Yeah, fine. So we've talked about heart rate, respiratory, so heart rate. So there's tachycardia in respiratory distress.
Whereas in respiratory failure, we expect bradycardia at that point.
Yeah. Okay, fine. So there's something that helps to differentiate that we must understand in this case now, appearance and capillary beds. So if the capillary beds, if the child is looking cyanotic, that is primarily with other signs, because a cyanosed child could still be in respiratory distress if the other signs are signs of respiratory distress. But by the time you have a cyanotic child with bradypnea and bradycardia, that child is getting towards arrest. Yeah, that's a bad spectrum. Yeah. So that's just like trying to differentiate between respiratory failure and respiratory. So we have already talked about these features in the previous slide. So I do not think we need to talk more about it. These are features of respiratory distress. Okay, so epidemiology.
Talking about the epidemiology, so generally, this respiratory distress is more prone in preterms, and for late preterms can be as high as 29%. However, in 10 babies, you can have it in about 15% of 10 babies.
So we can say the incidence increases with decreasing gestational age. It's an inverse relationship, between the incidence and the gestational age of the baby.
And some identifiable risk factors to respiratory distress. This could be both maternal as well as fetal, but so these risk factors include prematurity, meconium stained aspiration fluid, which should be found.
Yeah. So if a baby is born through meconium stained amniotic
fluid, yes. Then a delivery, CS delivery, which basically isolates or takes away the effort made by the baby. Then also in mothers with gestational diabetes mellitus and maternal chorioamnitis, as well as oligohydramnios.
Yeah. So gestational diabetes, many people will just stop and think about the hypoglycemia, right? But they are prone to respiratory problems. So respiratory distress, which could be respiratory or cardiac. So maybe we jump just a little talk about gestational diabetes. So the baby I went to receive in theater yesterday, macrosomic baby, infant of diabetic mother, came out, random blood sugar within the first 2 minutes of delivery was already hypoglycemic, right? So we will not stop at hypoglycemia. So their problems are not only metabolic. So we've also had children, the maternal hyperglycemia triggers hyperinsulinemia in the baby, which inactivates surfactants in these babies. So functionally, surfactant is available but non-functional. So they could have respiratory distress that presents just like respiratory distress syndrome. Well, if the surfactant sphingolipids, those ones are spared, they are also prone to heart muscle problems. Yeah, so they're also prone to heart muscle and shunt defects. And this will present with respiratory distress. So ideally, infants of diabetic mothers should be monitored closely, at least for the first few hours of life.
After birth. So now we're going to the WHO classification of respiratory distress. So 3 main classes: mild, moderate, severe. And if you look at the flow chart, basically we can use the rates and the clinical manifestation as well as oxygen requirements to make these differences. So for mild respiratory distress, if the respiratory rate is between 60 to 90, and also the oxygen requirement by the child is about 0.5 liters per minute.
So this baby does not have normal respiratory rates, but the range of tachypnea is limited to 90. So between 60 and 90, right? Yes. But this child, that's for mild, and this child is not using extra accessory muscles. So we just have basically the tachycardia limited to 90. And this child should saturate well with not so much of oxygen. Yeah. So, but when we have moderate, it's still the same kind of rate, but a lot of effort starts showing in. So a lot of effort starts showing in. So if we have 60 to 90 with effort, or more than 90 with or without effort, is moderate, right? So if we get above 90 with effort, then it's severe. So above 90, so we find babies that have respiratory rate of as high as 120. But this 120 without effort is still moderate. But 110 with effort is severe.
Severe.
So, and bradypnea sets in less than 30 per minute. This is severe because it's a spectrum from mild, moderate to severe to respiratory failure. So by the time we're having bradypnea and cyanosis, we are already at the edge between respiratory distress and respiratory failure. Yeah. So we are aware of some other classification schemes, but we'll just stop here because our interest is the type, the etiology.
Right. So talking about the causes, like we said, our discussion is focused mostly on the pulmonary causes as well as the cardiac causes. For the pulmonary, this could be parenchymal, which involves the lung tissue itself, or extra parenchymal. However, it's also important to know that there are other causes of respiratory distress, which in a lot of instances is best to first rule out before you start streamlining to other causes such as pulmonary and cardiac.
Yeah, so those causes, actually some, they are easily identifiable either by observation or some basic bedside investigations or examination findings. Take for example, disorders, a child that has sepsis is quite straightforward with its features of sepsis, although features of sepsis in units bizarre, quite plenty, right? But if you're already managing a baby for sepsis, the child has respiratory distress, you control the sepsis, antibiotics. Now, a baby in the neonatal intensive care unit should have intervals of monitoring the blood sugar levels. So hypoglycemia should be ruled out very, very fast, which is a metabolic cause. Also, the baby's temperature to maintain thermoneutral environment is essential. So we do not want to have hypothermia or hyperthermia. Now, looking at the babies, we could also tell for a baby in NICU, at least we should have full blood count. And from our observation, we can easily know the child is anemic or polycythemic. So these other features are easily identifiable by risk factors. If we take Perrobin sequence, for example, this child has an anomaly. We have a receding chin, all those features. So we can see coronal atresia. So this baby, we've been trying to pass a nasogastric tube and it's meeting an obstruction. So they are quite straightforward to pick up. So it's important to know that there are other causes. However, for the purpose of this presentation, we are going to just highlight pulmonary disease and cardiac disease. So under the pulmonary, we know we have parenchymal disease, which are lung tissue pathologies, and the extra parenchymal conditions. So we'll delve more into this. All right.
So talking about the parenchymal diseases, so first we have the respiratory distress syndrome, and then we also have the transient tachypnea of the newborn. We have meconium aspiration syndrome, we have persistent pulmonary hypertension of the newborn, we have neonatal pneumonia as well as pulmonary hyperplasia.
Yeah. So these ones that we wrote in fact, for the parenchymal disease, most of these ones are perinatal, so around the period of delivery, the causes. And we're actually going to dilate more on these. So not minding the abbreviations just for the purpose of space. So we're going to talk a lot on these. So we have the extra parenchyma, which are under respiratory, however, not actually lung tissue pathology. So a baby that has coronal atresia, which we talked about in the previous slide, but it's along the respiratory tract, right? So a child with pneumothorax. Now, you realize when we go in depth, there are connections between parenchyma and extra parenchyma. A baby that has meconium aspiration syndrome can rupture some alveoli from emphysema and all that and get into pneumothorax. But we are saying this baby we are meeting, what does the baby have? Does the baby have just a meconium aspiration? Does the baby have meconium aspiration with a pneumothorax, something different? So pleural effusion and congenital diaphragmatic hernia. We shall dilate more on it. But before we go forward, what are the risk factors for pulmonary disease? So because we've said, if you see a baby and you are able to tie up history, examination, investigations, you easily identify what the etiology is. So what the pathology is. So what are risk factors of pulmonary disease? So for transient tachypnea of newborn, we identify cesarean section. Most commonly elective cesarean section. So because the baby has not passed through the stress navigating through the birth canal, and baby is just brought out quite easy. So retention of lung fluids because the lungs are still filled with amniotic fluid in utero. So these babies are prone to retaining the lung fluid. So there is decreased space for aeration, for ventilation, perfusion. So they could come with transient acute nerve labor. Precipitous deliveries that the labor just starts and stops so fast. Yeah, so they still don't have enough time the contraction. Yeah, so gestational diabetes, we've talked about it, maternal sedation and all that. So for pneumonia, neonatal pneumonia is a process, is a condition that is closely related to neonatal sepsis. So when the mother is a carrier of group B streptococcus, the child is at risk of neonatal pneumonia. Then those who have had rupture of membranes that became infected, that's the amniotic fluid became infected, also another risk factor. Then babies born premature are at risk of neonatal pneumonia, which is one of the diagnoses, pulmonary diagnosis of respiratory distress.
Yeah. We also have respiratory distress syndrome, and also known as the hyaline membrane disease, which is common in prematurity. So automatically, it's a risk factor for babies as well. We also have gestational diabetes mellitus and multiple gestation. Well, in multiple gestation, for example, a lot of them don't get to term because of the size, and also a lot of the babies come premature, which also puts them at risk of respiratory distress syndrome.
Okay, so for respiratory distress syndrome, if we would like to talk a little about the difference between respiratory distress syndrome in a term unit and respiratory distress in a preterm unit. So term units that could have respiratory distress syndrome, infants of diabetic mothers, where we've explained before, whereas in prematurity is a quantitative deficiency in surfactant. In GDM, it is a qualitative deficiency, right? So it is formed, but it's non-functional, it's inactivated by the metabolic problems. Yeah, so also children with perinatal asphyxia, they could be born term, but still have respiratory distress syndrome. So meconium aspiration is so straightforward. A baby that is born through meconium stained amniotic fluid. So you find the baby mostly post-term or an asphyxiated baby that the inner sphincter became lost tone and the baby passed meconium in utero. So we find the digits, the nail beds, the fingernails stained with meconium, the umbilical cord stained with meconium. That kind of a baby, if the baby has respiratory distress, our minds go first to meconium aspiration. That does not exclude the baby who had a background cardiac condition from having meconium aspiration, but we will think of meconium aspiration very, very fast because it's something that can be done and taken care of almost immediately. Yeah, so we will now look at the cardiac causes. Yeah.
So looking into the cardiac causes, most of them are cyanotic congenital heart defects.
Yeah.
And they present with cyanosis, tachypnea, and the other spectrum of symptoms that children with respiratory distress come with. But then there are also the class of children with congenital heart defect, known as a critical congenital heart defect. These ones usually present within hours of birth, and there's actually a window of
less than 72
hours, which is crucial in order for an intervention to be done appropriately.
Yeah, so we'll see the next slide. We're talking about critical congenital heart diseases. So, but let's look at the examples of cardiovascular diseases that can manifest with respiratory distress. So cyanotic congenital heart diseases that manifest in the newborn period, and selected cyanotic congenital heart diseases. Maybe those with very large shunts, right? Now, neonatal cardiomyopathy, yes. So why? Why should a neonate have? Yeah, so we've made publications from our neonatal unit. But in fact, one of the publications titled Hypertrophic Cardiomyopathy in a missed. So the mother had gestational diabetes, but was missed in a peripheral hospital, and the baby came with hypertrophic cardiomyopathy presented in respiratory distress. Now, antibiotics will not work for that child. Antibiotics don't work. So the diagnosis had to be made by echo. The child was in heart failure, had to be placed on propranolol and other. So neonatal cardiomyopathy. So it could be hypertrophic cardiomyopathy. We also diagnosed restrictive cardiomyopathy in newborn period. These babies will present with respiratory distress. Now for pericardial effusion or cardiac tamponade, whatever causes an effusion in utero, where there is fluid in the space between the viscera and the parietal pericardium. Yeah, it should just be lubricated for normal diastolic expansion and filling and then contraction. But when we have fluid there and the pressure rises to restrict diastolic filling, so these babies are contracting, but with every ejection phase of the cardiac cycle, very little blood goes out. So these babies have respiratory distress. They present in cardiac tamponade. Yeah, so fetal arrhythmias. Yeah, so we've also made diagnosis of supraventricular tachycardia in our neonates. So supraventricular tachycardia with its own peculiar ECG features. Now, the last two presentations from Limit Children Hospital was actually on electrocardiogram, where we demystified ECG in pediatrics. There we presented the findings of fetal of neonatal arrhythmias. The baby had supraventricular tachycardia. Here the cardiac function is compromised. Time for diastolic filling is also restricted. So high output failures can also cause it. Babies with hydrops fetalis, those ones who still survive it. There is rhesus isoimmunization, right? And there's lysis of the red blood cells. So there is anemia, and the anemia places the child on high output failure. So it has nothing to do with respiratory system. There is failure of cardiac function because of a hematological problem, right? So high output failures will also manifest with the normal features of heart failure, which respiratory distress is inclusive. Yeah. So critical congenital heart disease. This is just one out of the cardiac causes we listed. Yeah.
And it's that 1 out of every 4 congenital heart defects in babies are critical. And like we highlighted earlier, there's a window of opportunity that says within 72 hours that is quite important in order for us to make an assessment as well as intervene in order to help the outcome of the child.
Yeah, so we have to intervene quickly because one of the easiest intervention for babies with critical congenital heart disease, you want to ensure mixing of blood. You want to ensure that either the ductus arteriosus is kept patent, because ductus arteriosus is necessary for quite a lot of the critical congenital heart disease. Now, there are 4 classes of critical congenital heart diseases. Those ones with parallel circulation and non-mixing. Parallel circulation, non-mixing, that's one. Right ventricular outflow tract obstruction, left ventricular outflow tract obstruction, and then anomalous venous connections. So those are the 4 classes. Now, so probably apart from the anomalous, even the anomalous venous connection, we still require an ASD for the babies to survive. But for the other 3, we require a PDA. So if we do not identify and keep the ductus arteriosus patent using prostaglandin E, these children will just move from respiratory distress to respiratory failure to cardiac arrest. Yeah. So how do they present? Cyanosis, yes, with desaturation, cardiac failure, which will ultimately present with respiratory distress. And where we've mentioned shock, although shock is not part of our presentation today, it's just one of the ways that critical congenital heart diseases present. We shall take a look at them one by one. Before we delve into distinguishing the critical congenital heart diseases that present with respiratory distress, I want to re-emphasize the 4 classes of critical congenital heart disease. So critical congenital heart diseases with parallel circulation and non-mixing. Parallel circulation, that's one. And then the critical congenital disease with left ventricular outflow tract obstruction, that's 2. Critical congenital disease with right ventricular outflow tract obstruction, and then those with anomalous venous connections. So yeah, so we start with the first one.
So the first one is transposition of the great arteries, and that's the dextro form of it, because there are two forms of it. Now, like we highlighted a minute back, that there is the critical congenital heart defect with the parallel circulation non-mixing. Now, looking at this image on the screen, we can see the blood flow going parallel to each other, both on the left and on the right. And what happens in transposition of the great arteries? Basically, the artery, the aortic outlet that's meant to be on the left is found on the right, while the pulmonary outlet that is meant to be on the right is found on the left, which means that blood that goes into the right atrium to the right ventricle, rather than going to the lungs for oxygenation, goes through the aorta to go back into the system to repeat the cycle. However, the blood that gets into the left atrium, usually through the patent ASDs, goes from the left atrium to the left ventricle, then goes into the pulmonary circulation, gets oxygenated, and then goes back into the heart. Now, in this condition, there are two parallel circulations that are occurring independently. However, due to the presence of this ASD, which is why we highlighted that it's quite important for us to have a patent ASD, the oxygenated blood on the left gets to mix with that on the right, and which now has a mixed circulation that can go into the system and give the child a bit of oxygen, although not the needed oxygen, but then get a bit of oxygen.
So in this diagram, the two places where we could have admixture is in the interatrial septum and after the vessels where a PDA is actually needed, though not shown in this diagram. So the ductus arteriosus is a fibrous connection in utero between the inferior surface of the descending aorta and the superior surface of the main pulmonary artery where it bifurcates, right? So we need that connection for admixture. Else, these babies will just keep circulating deoxygenated blood on its own, and oxygenated blood and won't last. Now, back to our definition of critical congenital heart diseases, we should be able to identify and intervene in less than 72 hours. So what should we do in this condition? If we have a PDA, we maintain duct patency using prostaglandin E1. If we need an ASD, then a balloon atrial septostomy has to be done to create mixture at the interatrial level. So that's one of them, the dextro transposition of great vessels. Because cyanosis will manifest from systemic deoxygenation, this child will be cyanosed, right? And because the lungs just keep circulating oxygenated blood, not going to the system, it moves from cyanosis terminally, the child gets into severe respiratory distress. Now, for cardiogenic shock, which will now still premature respiratory distress, for children with hypoplastic left heart syndrome, we see in hypoplastic left heart syndrome, there is a pathology with the left ventricular inflow tract, which is the mitral valve. So there's a problem, stenosis there. Now, the left ventricular chamber is diminutive, that is, it's hypoplastic. And then there is severe obstruction of the left ventricular outflow tract. So oxygenated blood gets into the left atrium and shunts through an atrial septal defect, gets into the right chambers. Now, we understand that the right chambers should be smaller than the left chambers, but when the right chambers become the chamber that everything is happening hemodynamically, there is a severe enlargement of the right chambers. So blood now gets through out through the pulmonary right ventricular outflow tract, into the main pulmonary artery, and through a patent ductus arteriosus. That is how the systemic circulation will be fed. So oxygenated blood mixes with deoxygenated blood, and then that deoxygenated one gets into the systemic circulation. That kind of a child will present with cyanosis, will also have respiratory distress, and would have shock because the volume of blood in systemic circulation will be less than what is required. Now, coming to other critical congenital. So we've talked about the one with parallel circulation and the left ventricular flow tract obstruction. So for right ventricular flow tract obstruction, we find this child with, this schematic diagram, with an atretic pulmonary valve. So it's actually total occlusion, not just stenosis, not even severe stenosis. This is atresia, right? So blood enters the right atrium, venous return from superior vena cava and inferior vena cava through the tricuspid valve into the right ventricle. Normally, it should simply go through the right ventricular flow tract to the main pulmonary artery, then branching to the left and right pulmonary trunks. But unfortunately, this door is closed. So it has to do another merry-go-round, bounce backwards. So there will be a tricuspid regurgitant jet, and then that blood now jets through the atrial septal defect. From the atrial septal defect, gets into the left atrium, from the left atrium through the mitral valve to left ventricle. Before it gets through the aorta, ascending aorta, it's only at the point of the arc of the aorta where the ductus arteriosus now helps to channel the blood that was deoxygenated to now go back into the lungs via the pulmonary arteries, left and right pulmonary arteries. So we see something that should have just gone straight bifurcating. We have a lot of merry-go-round. These children present with cyanosis primarily, and there's so much little blood going to the lungs for oxygenation, right? Because of just the ductus arteriosus is like salvaging the system. The child will also have respiratory distress. Yeah, so that's another one. So we could also have another variant where there's a pulmonary artery with a ventricular septal defect. That is a variant of tetralogy of Fallot. So tetralogy of Fallot has its own. So a tetrad of intracardiac pathologies, including a ventricular septal defect, an overriding aorta. But the main pathology is a right ventricular flow tract obstruction, which back pressure effect will now cause hypertrophy of the right ventricle. Yeah, so, but this is for this case, it's a pulmonary atresia with intact ventricular septum. A pulmonary atresia with a ventricular septal defect will also have cyanosis, but arguably not as severe as that with intact ventricular septum. So total anomalous pulmonary venous connection, as depicted in this diagram, we have oxygenated blood from the lungs, where we have the two pulmonary veins joining, forming a plexus, a confluence of veins, and then the connecting vein bypassing the left atrium into the right atrium, either directly or via connection with the superior vena cava. So deoxygenated blood gets into the right chambers. Oxygenated blood also gets into the right chambers, right? So blood that gets into systemic circulation only does that via an atrial septal defect. This baby will require a balloon atrial septostomy if we do not have a functional atrial septum. Mind you, the patent foramen ovale on its own closes physiologically. So we actually require something structural like an atrial septal defect. But why do these children have respiratory distress? There's an overflooding of the right chambers, and so the lungs are overflooded. So there's pulmonary edema and then respiratory distress. So in summary, we've talked about that for cardiac. We talked about 4 broad classes of critical congenital heart diseases. One with parallel circulation, like the dextro transmission of great arteries, then the left ventricular flow tract obstruction, which is the hypoplastic left heart syndrome. Mind you, there are other variants of left heart obstruction, like critical aortic stenosis. Yes. So there are other ones, hypoplastic aortic arc. Those are all obstruction of the left ventricular outflow tract. Yeah, and these ones we've talked about. So let's make progress.
Okay.
Well, so we just want to be sure our participants are with us and that you participated fully in the series of presentations we've been doing. So we want to test our audience. Let's just be sure we've been talking sense, right? So sit up and let's get your responses in this first clinical scenario. Actually, we have like 4 clinical case scenarios in this presentation, and we have one very simple quiz. So clinical case scenario 1.
Okay, so the first case scenario is a 38-hour-old female neonate that presented to the NICU. The child was in respiratory distress because she had difficulty in breathing, and also had darkening of the oral mucosa, which indicates cyanosis.
Yeah.
On examination, the child was in severe respiratory distress with central cyanosis. The SpO2 in room air was 31 to 40%, and on administration of oxygen, there was no significant change that was found in this child.
All right, fine. So now, so we did an urgent echocardiography for this baby, and we found that the child had multiple atrial septal defects, actually two. One was 14 millimeters, the other one 4 millimeters. So giving a wide defect of about 18 millimeters. And so the child had physiologically a single atrium, right? There was severe tricuspid regurgitant jet velocity with a maximum velocity of 4.25 millimeters, that's meters per second, sorry, not millimeters of mercury, is meters per second. It will be corrected at the slide that will be given to you. Now we know that the velocity, once we are getting above 2.5 meters per second, sorry, not millimeters of mercury, meters per second. Yeah. By the time we are getting above 2.5, we are having increased pressure, pulmonary pressure. We also found that the right ventricular chamber was markedly enlarged, and we had a squashed left ventricle, small left ventricular cavity, and the left ventricular flow tract obstruction was quite severe. There was moderate pulmonary regurgitation also. The child had a patent ductus arteriosus about 3 millimeters in diameter, and also had a right to left shunt. Yeah. So we would like to have answers into the Q&A. So we've read your comments. Please. We understand that the chat box are disabled. Yeah, the chat box are disabled, but just put your answers in the Q&A, right? So this is a clinical case scenario. Just look at it again. Respiratory distress, cyanosis, non-response to oxygen, echo features showing problem with the left ventricular cavity, the right ventricular is enlarged, there is ASD, there is PDA, right? So now, question regarding the case above, the correct statement is, so please give us the answer in the Q&A if you are really following us. So what are the options?
So the first option is the high flow of oxygen therapy is essential in this child. We also have the patient to benefit from urgent balloon atrial septostomy. The child needs surgical interventions as soon as possible. And the last is mortality is uniform regardless.
Okay, fine. So uniformly 100%. So let's see, we've already started having answers. Wow. This is interesting. Yeah, so we have some answers already. But let's just watch and see a few more people. Yes. So I think our audience is following. This is excellent. Oh, we have somebody that chose the wrong answer but won't reveal your identity. Don't worry. That's the beauty of it. So nobody is looking at what you wrote except us, right? So regarding this case above, high flow oxygen therapy is essential. No, not essential, because mind you, well, it did not improve oxygenation. Mind you, oxygen is a pulmonary vasodilator, and this child already has a patent ductus arteriosus, so it will further dilate pulmonary circulation and worsen respiratory distress. So option A is wrong. Child benefit from urgent balloon atrial septostomy. The child already has almost a single atrium physiology. The child was blessed with large atrial septal defect, right? Okay, mortality is not uniformly 100%. The purpose of this presentation is to take care of mortality. In Limit Children's Hospital, we want to contribute to Sustainable Development Goal 3, the second target, which is that we want to reduce avoidable deaths in newborn babies and older children by the year 2030. We give ourselves even a shorter timeline. So mortality is not uniformly 100%. Now, this child needs surgical intervention as soon as possible. Yes. So we are happy that quite a lot of people got the answer. So the answer is not B, the answer is not A, the answer is C. And the diagnosis here is actually hypoplastic left heart syndrome. Thank you, our dear audience. So we'll make progress. Yeah, so now, fine. How do we differentiate between cardiac versus respiratory causes of respiratory distress.
Correct. So one of the things we could use in differentiating them at presentation is the onset of timing.
Yeah.
So for respiratory causes, now the etiology is variant, which means the onset of symptom also is variable. However, in cardiac, like we really emphasized on the 72-hour window, which means that the duration of intervention is very important, and also the symptoms are also quite severe as at the point when you're seeing the child. Now, we put the flow chart there to help differentiate between preterms and term babies, and to look at how at the point when the symptoms are manifesting, using the age, post-conceptional age, to help narrow down which of the causes it might be. So for preterms, if the baby is if the symptoms are less than 6 hours old, then you'll be thinking of highly membrane disease, which is the same thing as respiratory distress syndrome. You'll be thinking of neonatal pneumonia, lung anomaly, or possibly shock. But if it's a symptom manifesting about 6 hours after life, you also still think of pneumonia, but then you start thinking of congenital heart defect and pulmonary hemorrhage. While for 10 babies, if it's less than 6 hours, we're thinking of persistent pulmonary hypertension of the newborn, thinking of meconium aspiration syndrome. If the child is greater than 6 hours, we're thinking of also pneumonia, which means across spectrum, pneumonia is one of the major things you should always consider, and why it's quite important to also have a good history, because you can rule out possibilities from the history. Then also it could be congenital heart disease.
Yeah, so pneumonia is part of sepsis in newborn babies. So if it's early onset neonatal sepsis, is less than 72 hours. It depends on how early it's occurring. So it can occur less than 6 hours or even more than 6 hours within the confines of early onset neonatal sepsis. But interestingly, most of the cardiac causes will not occur within the first 6 hours. But mind you, cardiac causes are not restricted to only congenital heart defects. So we've mentioned quite like hydrops fetalis, supraventricular tachycardia, even the cardiomyopathies. Fine. So, but they commonly would manifest after 6 hours. Although those that are critical will manifest within the first 72 hours. It becomes really severe. Right.
Also, another symptom we could use is the work of breathing. So in respiratory distress, they might have retraction, which shows that a lot more effort is being put at the point of manifestation. So they're having subcostal recession, intercostal recession, whereas in cardiac...
Yeah, and that's a lot because of ventilation perfusion mismatch.
Yes.
The pathology is primarily respiratory, and so there's a lot of ventilation perfusion mismatch. So they use excess efforts. Yeah.
And while for cardiac, it's really just might be tachypnea for the longest period before you start having symptoms of retraction, which might be tilting towards, maybe the child is going towards respiratory failure because no intervention was offered in due time.
Yeah.
Then also cyanosis is one of the things that we could use in differentiating. For respiratory, if you remember how we talked about the cardiac causes and their pathology, most of the cardiac causes have cyanosis as a major symptom. However, in the respiratory diseases, the cyanosis are usually uniform, whereas in cardiac, we have what we call differential cyanosis and reverse differential cyanosis.
Yeah, so cyanosis is, so basically we all know from, let's say, elementary, right? Those of us that went to good primary schools, they taught us peripheral and central cyanosis. I didn't go to that kind of primary school. Yeah, so now from medical school, we know that we have this differentiation between peripheral and central cyanosis. That's no, we're not talking about peripheral cyanosis here. Basically still central cyanosis, but for respiratory causes, uniformly cyanosed, right? But for cardiac, most cardiac causes will not be uniformly cyanosed. And that's a good takeaway from this presentation. Now, in differential cyanosis, we have a sparing of the upper limbs. So we have a sparing of the preductal oxygen saturation, whereas the lower limbs are not spared. So we have cyanosis where you have more cyanosis in the lower limb as compared to the upper limb. Now we'll come back to that. Now for reverse differential cyanosis is the other way around. You have more in the upper limbs and less in the lower limbs. So why this differentiation? You could actually make an almost accurate diagnosis by a close bedside observation and almost accurate diagnosis of the cardiac pathology by studying the kind of cyanosis these children have. So if we say for differential cyanosis now, we said the upper limb is spared. In that condition, pre-ductal saturation will be far better than the post-ductal. So in conditions where there is a right to left shunt, let's say for example, we know that the aorta, the arc of the aorta, the aortic root comes out of the left ventricle, the aortic root to the ascending aorta, to the arc of the aorta, then the descending aorta, right? Now, and the arc of the aorta has 3 branches generally. So the brachiocephalic trunk comes out first, that bifurcates into the right subclavian artery and then the right common carotid. The next set of vessels are the left, that supply the left side, which you have the common carotid and the left subclavian artery. Now we know that the ductus arteriosus comes, the position can vary, but let's assume that the position of the ductus arteriosus is at the isthmus after the left subclavian artery. Now it means that blood coming from, and we have a pathology with a right to left shunt, like persistent pulmonary hypertension of the newborn, right? So in that condition, there's a patent ductus arteriosus, but the shunting is right to left. So deoxygenated blood gets into systemic circulation through a PDA. And that PDA is joining the systemic flow after oxygenated blood has been given to the upper limbs, right? So the upper limbs are spared, whereas the lower limbs are cyanosed. In fact, the echo done this morning for the baby that was present pulmonary hypertension of the newborn and had that differential cyanosis, real life. And then the child had a PDA, right? So that's differential cyanosis. For reverse differential cyanosis, the upper limbs are more affected. So there's cyanosis generally, but the upper limbs are more cyanosed than the lower limbs. What explains this? When we have a detransposition of great vessels, we are sure our listeners understand the difference between the level transposition, and the dextro transposition. In dextro transposition, it is a ventriculoarterial discordance. So there's a discordance between the ventricle and the vessel that comes out of it. So the left ventricle is feeding the pulmonary trunk, which should have been on the right, and the right ventricle is feeding the aorta, which should be from the left. So that's what we call a ventriculoarterial discordance. So in reverse differential cyanosis, you realize that the aorta, which is carrying deoxygenated blood in DTGA from the right ventricle, which is deoxygenated, is supplying systemic circulation. So again, it would have supplied the upper limbs before the shunt, the PDA, which is now left to right shunt, will be diluting the PDA that's helping oxygenated blood to get into systemic circulation, right? So the part of, from the descending aorta, where the PDA carrying oxygenated blood joining now will have less cyanosis than the part that was fed with blood that was purely deoxygenated. So that's reverse differential cyanosis. So from bedside, we can make a lot of clinical judgment about these babies in respiratory distress. Yeah. So we talk about auscultation now. So we've looked at history, which is onset of the breathing. We looked at inspection, which is the breathing. We've looked at inspection, which is cyanosis. So we go to auscultation. In auscultation, everybody wants to check, does the child have a murmur? The child does not have a murmur. We are not talking about murmur yet. Let's talk about the nitty-gritty of the heart sound. We know that the first heart sound occurs because of the vibrations. We hear the first heart sound using our stethoscope because of the vibrations set up from the closure of the atrioventricular valves, right? So the mitral valve, the tricuspid valve, no problem. So if we look at this diagram, expiration, inspiration, we have S1. So we usually have our S1, no problem. Yeah. So, but physiologically, we usually say S1, S2, but S2 actually is a combination of A2 and P2. So now, second heart sound is caused by the vibration set up from closure of the semilunar valves, the outlet valves. And the two outlet valves are aortic valve and pulmonary valve, yeah. So we know that during inspiration, there is a delayed filling of the left chamber. So the left chamber is more filled. So it's already delayed emptying. So it takes at the ejection phase of the cardiac cycle where blood leaves the cardiac chambers, blood is leaving the left ventricle into systemic circulation. But it takes a longer time before that ejection phase is completed in the right ventricle. So the aortic valve will close faster, yeah, than the pulmonary valve. So there is A2 occurring earlier than P2 during inspiration, whereas during expiration, they are occurring almost together. Why are we bringing this to differentiate between pulmonary cause of respiratory distress and cardiac cause? We can make a lot of, even without echo, we can make almost accurate diagnosis from just auscultating for our P2. Now, we want to say that clinicians will pay more attention to second heart sounds because many times we just say S1, S2 present, and so you will just laugh. When you say that to a cardiologist will just laugh. What is S2? Tell us more about the S2. Now, if we auscultate for normal heart sounds, it's actually first, second, yeah, is second as one during inspiration, but the second is splitted during inspiration. So you will hear lob, dop, lob, drop, lob, dop, lob, drop. So in the drop, if that is how it sounds, right? So you just know that there's a splitting. So one of it is splitted, and the intensities are the same, unlike momo, where the intensity of a momo is different from that of the actual heart sounds, right? So now in respiratory causes of, in pulmonary causes of respiratory distress is a normal splitting. So you have one heart sound during expiration, one S2 during expiration, and you have two during inspiration. That is normal. But when you have pathologies, abnormal splitting of the second heart sound, you think of a cardiac cause, right? So if the splitting is wide and fixed, it's wide and it remains just like that. It's fixed, whether inspiration, expiration is wide, you can hear it. But what you're hearing is lob, drop, lob, drop, lob, drop, just continuously. Now let's see, an atrial septal defect can cause this. Why? We will explain. A partial anomalous pulmonary venous drainage can cause this. Why? We will explain. Pulmonary stenosis can cause it. Why? We will explain. And all this can cause it. Yeah. So in atrial septal defect, there is a shunting from the right, so from the left chamber, that's left atrium to the right atrium. So the normal venous return into the right chamber remain constant from SVC and IVC, remain constant. But more blood is now entering into the right chamber, right? So with the normal delay in closure that will occur during inspiration, more blood is coming. So it takes a longer time for the pulmonary to close when there is ejection of blood from the right chamber. And because the shunt is a constant thing, the splitting is fixed. So we have widely split. The same thing occurs in partial anomalous pulmonary venous return, because in anomalous venous return, more blood enters into the right chamber. So there is more blood, and then functionally the space, the right ventricular flow tract, which ab initio is not necessarily structurally stenosed, will become sort of functionally stenosed because so much blood wants to go out, and so it takes a longer time. Now, pulmonary stenosis as a cause of widely split and fixed second heart sound is so obvious, because if the pulmonary valve is stenosed, then a lot of pressure and a longer time for the right ventricle to eject its blood in the ejection phase, right, of cardiac cycle. So it's going to close later than the aortic. So it's widely split and fixed. Now, in pulmonary hypertension, like present pulmonary hypertension of the newborn, yeah, it's also split, but it's narrow because it's a pressure-related difference. Now, S2 can be single. In this case, we are just hearing lobbed up. So there is no splitting of the second heart sound. That kind of a condition occurs when one of the semilunar valves is atretic. So, you need two, for the two of them to close at different times for you to hear a split. Yeah, so two of them close at the same time is not split, but because there are two functional valves, closing at different times is split, right? But you don't have one valve that is totally blocked. So the second heart sound is only attributable to one of the functional valves. So in pulmonary atresia, there's complete atresia. Nothing is happening. So it's not setting up any vibration. It's only the vibration of the aortic valve that is accounting for the S2. Yeah. The same thing with aortic atresia. In aortic atresia, nothing is even occurring. So normally A2 comes before P2, but A2 does not exist. So it's just P2. Tricuspid atresia is similar to pulmonary atresia because in tricuspid atresia, no blood even gets into the right ventricle chamber. So no blood goes out. So that's what it is. So there's paradoxical splitting in severe aortic stenosis. So we've spoken a lot about cyanosis, about cyanosis, where you can actually guess with so much accuracy if the kind of congenital heart disease. We've also expatiated on the splitting of the second heart sounds. Yeah, so we could have momo, we may not have momo. So for example, if it is a pulmonary atresia with intact ventricular septum, we may not even hear momo, but it was a critical congenital heart disease. So presence or absence of momo does not completely rule out or really mean congenital heart disease. But if you hear a momo, do echocardiography. Yeah. So yeah.
Also the response to oxygen, like we highlighted earlier, for respiratory diseases, response to oxygen usually shows a significant change in the child. However, because it's from the pulmonary cause. However, if it's cardiac, there might not be any significant change on administration of oxygen depending on the origin. Then also we'll be looking at some imaging studies in subsequent slides.
Yeah, so good.
So first is this slide, which is a child that has transient tachypnea of the newborn. And this is also known as fetal lung fluid syndrome that we highlight earlier said. And the child presented in respiratory distress, or child was tachypnic, there was increased work of breathing. However, on the chest x-ray, we can see the diffuse
so we see features of retention of the lung fluids. Yes. So see where the arrow points. See where the arrow points. There is this white, let me call it white tissue running. So yeah, white shadow. So the fissures between the lobes of the lungs still retain fluid. Yeah. So they still retain fluids, and then with the opacities that you find around. So just that clear evidence of fluid in the fissures in a child that has tachypnea that was delivered by cesarean section at 10. Yeah, so it's important that clinical history is tied up with the radiological finding. Yeah, okay, fine. So we want to have a case scenario. So we believe we've spoken a lot again. We want to test our audience to know if we are making sense. So just sit tight and let's hear from you at this time.
So our second case scenario is of a male neonate that was born preterm at the 3 weeks gestational age. His weight was 1,500 grams. His ABGAS score was good. However, on examination of features of subcostal recession, grunting, and nasal flaring, as well as cyanosis, hence requiring the child to be on CPAP immediately after delivery. On auscultation, there was reduction of air entry in all lung fields. The temperature was normal, however, this child was tachycardic as well as tachypneic.
Yeah, okay. Yeah, so someone asked a question. Please, would you share your slides with us? Yes, we will share the slides with you. I think that helps to answer that question. So we find this child that is tachycardic and tachypneic with increased work of breathing that is preterm but delivered SVD. So what could this be? What could this be? Let's look at this chest X-ray. We have this facing us. What radiologic features are evident here? That's the first question. We are not asking about the diagnosis. What can you see? So would you mind giving us answers in the chat box? What can you see from this? Because once you are able to identify what is on the X-ray, you will be able to know what we are treating. So we give us a few minutes, few seconds. Let the answers come rolling in. Let's hear what you have to say. So while we wait for you to give us responses, we would like to point out a few features. So if you look at the X-ray very well, I hope your screen is clear enough. There is this appearance, which is classic. Okay, we have some answers coming already. Okay, so with the first answer, someone said cardiomegaly. Let's look at it. We were not after cardiomegaly actually. Yeah, so we have, yes, ground glass appearance, another person, ground glass appearance. This is so good. Patchy opacity suggestive of bronchopneumonia. No, we will still show bronchopneumonia. So white ground glass appearance. Yeah, perfect. So this is clear. So this is ground glass appearance. Now we are tying up a child that has a ground glass appearance on chest radiograph with a child that was born preterm respiratory distress. So what possibly could it be? So the next question follows. So possible diagnosis, what possibly could be the diagnosis for this preterm with ground glass appearance? Wow. So we have answers flowing already. So but we will not make any comments whether this answer is correct or not. Let's wait and see from other people. Yeah, so yes. Yes. So fine. A lot of answers trickling in. Yeah, so that's very good. Very, very good. Very good. Yeah, so we even have more answers coming. So the first answer, this is respiratory distress syndrome. This is respiratory distress syndrome. We have had people already answering which is preferable. So what is preferable? Because we have antibiotics everywhere. So do we just start giving ceftazidime, gentamicin, unacin? Let's see, should we give antibiotics or should we give surfactant? We already have a lot of answers flowing in. So yeah, so we give surfactant. We give surfactant. We give surfactant. Yeah. So how may this diagnosis be prevented? Very good. So let's see, we want to prevent it. How may we prevent respiratory distress syndrome in our environment? In a preterm, yeah, in our environment. Yeah, so let's see, we have some answers for it. Oh, yeah. Okay, so this question has two answers. How may we prevent respiratory distress syndrome? If we do not have preterm births, if we avoid preterm delivery, we will not have respiratory distress syndrome from the neonates. Yeah. But the other answers flowing are so correct. Antenatal steroids, dexamethasone, steroids. Yeah, so prevention should start with antenatal care to avoid preventable preterm births. Perfect. So if we're able to avoid it, yeah, but in the event it occurs, then steroids become very, very important. This is where a functional perinatal unit becomes very important, with the obstetrics and gynecology unit working very closely with the neonatology unit. All right, fine. So far, so good. Let's make progress. Yeah, so, oops, we've already put the title glaring. I wish we could remove this title, neonatal pneumonia, but the X-ray is clearly in front of you there. So neonatal pneumonia is part of neonatal sepsis. So unlike older babies in pediatrics where the pneumonia the lung infection is localized to the lungs. In pneumonia for neonates is part of neonatal sepsis process. And it should be attacked with all aggressive as taking blood culture, cerebrospinal fluid culture, and initiating broad spectrum antibiotics. So what can we see? What may we see? We didn't ask it as a question. But from our listeners, what can you identify? Okay, somebody asked a question. Please, does splitting of heart sounds occur in normal people? Yes. The answer is yes. It occurs in normal people because there should be splitting of the second heart sound during inspiration. During inspiration, because the filling of the right chambers takes a longer time. So expelling of blood, ejection phase is slower. So the pulmonary valve will close later than the aortic valve during inspiration. So yes, that is called physiologic splitting. But when the splitting becomes fixed in both inspiration and expiration, then that's the problem. Or when there's a paradoxical splitting, with the splitting occurring in expiration and not in inspiration, like that. So though that one becomes pathologic. So the question here is, what may we identify in the chest radiograph of a baby with neonatal pneumonia? Well, we would, since we already gave the diagnosis, we'll go ahead and see. So there are bilateral patchy opacities and presence of air bronchogram sign. So to identify an air bronchogram sign, we know that air, or rather gas, on chest X-ray is dark and soft tissues will be white. So air bronchogram is that there is air in the air channels that can be seen, whereas the channels itself has the opacity. So we can see an air bronchogram sign. My marker is quite broad. So there are air bronchograms present in this X-ray, and then the patchy opacities. Yes. All right. So this is meconium aspiration syndrome. Yeah.
The meconium aspiration syndrome, of course, we already have respiratory distress, and the chest X-ray finding will show diffuse patchy infiltrates, and this is usually as a result of inflammation within the lung tissues as a result of the meconium in the lung tissue. And these are the just a diffuse patchy infiltrates everywhere in the lung tissues. Also, with underlying history of meconium stained amniotic fluid. In the mother.
So a baby born through meconium stained amniotic fluid that has these fluffy opacities. Yeah, much like that of a pneumonic process, but there are no classical air bronchogram signs. Yeah. And then if echo is done for this child, there will be pulmonary hypertension. We will see why. So these are the mechanisms of pulmonary pathology in meconium aspiration.
Also, for meconium aspiration syndrome, there are three main parts for the pathology. The first is mechanical obstruction of the airways, and that is a result of displacement of the meconium. Also, that's for the mechanical obstruction of the airways. Also, there could be complete obstruction. So for the first is complete obstruction, which could result in atelectasis. And then also, we also have the partial obstruction, which could result in bulbar air trapping and then obstructive emphysema, and which can subsequently result in pneumothorax.
So that's it. So pneumothorax is a non-parenchymal cause of respiratory distress, while the meconium aspiration itself is parenchymal. So meconium aspiration is a classical diagnosis where you could have both parenchymal cause of respiratory distress and the non-extra parenchymal cause from the pneumothorax. So in chemical pneumonitis, which is another cause mechanism of injury, there is induction of inflammatory cytokines by the presence of irritation from the meconium. Yeah, so this results in parenchymal injury,
and then vascular leakage, and then also the symptoms of respiratory distress.
So
then we also have the surfactant inactivation, and because of the presence of meconium, it alters the phospholipids in the surfactant, as well as results in reduction in surfactant production. As such, the child is unable to produce or use enough surfactant available to it to be able to breathe normally.
Yeah, so you see, meconium aspiration syndrome, we chose to talk a lot about the mechanism because the child, the X-ray, there is no one X-ray pathognomonic. It depends on what stage you are meeting the child, the neonate. So if the neonate does not have a pneumothorax, then we could say the X-ray features that we found in the previous slide. Yeah, so the X-ray features, this does not have a pneumothorax. So it's just the opacity from aspiration. The aspiration causes just those inflammatory changes, right? So, but if we have pneumothorax, then the picture changes, right? Now, remember that the chemical pneumonitis causes injury that is similar to acute respiratory distress syndrome. So that ground glass appearance could as well be there from the acute respiratory distress syndrome. Yeah, because surfactant is really, really affected. So part of the treatment for these babies includes surfactant administration. Yeah. Okay, so just to summarize the pathophysiology which we've been talking about, is that there's meconium in the amniotic fluid as a result of which leads to postpartum aspiration. Yeah. So when meconium aspiration occurs, it can either cause airway obstruction, cytokine-induced pneumonitis, or surfactant inactivation. In any of them, there is hypoxia. Yeah, and then which leads to persistent pulmonary hypertension. Yeah. Away from pulmonary cause, let's get to some very interesting cardiac imaging that is just pathognomonic. Claire.
This picture is the popular egg on stream appearance that is seen in transposition of the great arteries. And when we're describing the manifestation of transposition of the great arteries, we did say that the vessels were inappropriately placed, which means the aorta is coming out on the right, whereas the pulmonary trunk is coming out on the left, which loses the arc of the aorta. So in such, we see this because usually the arc of the aorta contains the upper mediastinum, forming that shadow that we're seeing. But this is the classical egg on string appearance that is seen.
Yeah, so somebody, just for us to go a little backward, someone say, please, could you re-explain the air bronchogram sign? So let's go back to the air bronchogram image. So that is in, oops, oh, sorry. Okay, so neonatal pneumonia. So air bronchogram sign, there's air in the distal air passages. So air bronchogram, and air or gas on chest X-ray is dark, right? So we find a dark streak of line with clear cuts surrounded by cylindrical tissue of white. So we have the lucent dark area with the radiopaque edges like the tissue. So tissue forming like a cylindrical. So this is an air bronchogram. So you find the air bronchogram coming very close. A good magnification of the image would easily give the air bronchogram sign, which is there in neonatal pneumonia. Yeah, so we've talked about the egg on side appearance, egg on string or egg on side appearance, where the superior mediastinum is very narrow because, of course, there's a transposition of the vessels. Yeah. Okay, so the next one is figure of 8 or 7 sign. So yeah, so the snowman sign, you can see this for our babies, snowman. Yeah, so for our rhymes, for our pediatric guests. Yeah, so in figure of 8 sign, the normal cardiac shadow is there quite well. However, there is a plexus, a confluence of veins that left the lungs. Instead of entering the left atrium, the coalesce join either the superior vena cava, inferior vena cava, or directly into the right atrium. So this connection, this confluence is another plexus of tissue above the cardiac shadow itself. So it gives you the upper part of the 8, or the head of the snowman. Yeah, so that's for the snowman sign. Okay, thank you. Thank you. We are getting your comments. Yeah. So we'll make progress. We appreciate your staying with us. So let's give, so we're presenting our third case scenario now. Sit tight because we purposely made it a little more difficult than other cases. So doing math, this is like moving from mathematics to further maths. So let's go a little, let's step up a little bit.
So the third case scenario, which is also I think the last for this presentation, is a male neonate that was born at term. The birth weight was 3.4, delivered by a CS. On account of breech presentation, the APGAR score also was good at birth. However, 8 hours after delivery, the child was noticed to have severe dyspnea. Auscultation, a systolic ejection murmur was heard, which was loudest at the pulmonary area. Then a preductal SpO2 was 88% in room air. However, on administration of high flow oxygen, it went up to 98%. An echo was done urgently for this baby, and it showed pulmonary hypertension with a tricuspid regurgitant velocity of 3.2 millimeters per second.
And this is elevated.
Yes, that's because I'm booked up 2.5.
Yeah.
And also a right to left shunting was recorded across the restricted ductus aspiratus. No cardiac malformation was found in this child.
Yeah.
Yeah,
so what is the diagnosis?
What do we possibly think this
is? So what do we think is this diagnosis? Let's go back. This is a normal child, normal weight, good APGAR scores, everything was normal until 8 hours after delivery, and this child is in having severe dyspnea. We have the echo that we had murmur, and then we have echo showing a ductus arteriosus that is patent, and tricuspid regurgitant jet velocity is elevated. We have a preductal saturation, which ordinarily should be good, but it's 88, but this increased. So we have answers flowing already. Yes, but let's wait for some people. Someone has given the correct answer already. So let's see whether he will take the crown for today. He or she, because the name is unisex, so we cannot tell. So what could this be? We purposely made this a little more difficult than ready. Share screen. Okay, all right. So we really sincerely apologize for our break in transmission. That was a significant break, and we tender our sincere apology, and we appreciate those who have remained with us. So we make progress. Quite some people have given some answers, and I must say they are all, we are having a lot of answers. So so we are back again. So let us list the answers that were given, right? So we have persistent pulmonary hypertension of the newborn. We have tetralogy of Fallot. We have persistent pulmonary hypertension. Severe respiratory distress. Okay, fine. So for this child, what we have here is persistent pulmonary hypertension of the newborn. What happens here is that the babies are born, every other thing is otherwise normal. But these babies develop severe respiratory distress shortly after birth, and most times we would be able to auscultate a murmur. But remind you, we may or may not auscultate a murmur. Now, there is a difference between the pre-ductal and post-ductal oxygen saturation, which is sometimes more than 10%. Yes. Mind you, when we discussed differential cyanosis, we said that pulmonary hypertension of the newborn is one of the causes of differential cyanosis. So you do not expect on close inspection to find the extent of cyanosis to be the same at all, right? So echocardiography will show pulmonary hypertension, which is shown by elevated tricuspid regurgitant jet velocity. Anything above 2.5 is elevated. Now, the shunt lesions existing because there is need for shunts, atrial septal defect, patent foramen ovale, or patent ductus arteriosus. These are structural abnormalities that may be present in in basal pulmonary hypertension of the newborn. If you find a VSD, then it is not the basal pulmonary hypertension of the newborn. All right, so we use this. So what is the diagnosis? Basal pulmonary hypertension. So diagnostic options, echocardiography is a gold standard. Yeah, so but arterial blood gases can be used, and then pre-ductal, post-ductal oxygen saturation, post-oximetry. Yeah, treatment options. These children will require oxygen. Yes, these children will require oxygen for supportive therapy. It's usually transient. A lot of them will normalize with time. Yeah, so how do you know progress is going on? Respiratory rate is dropping, saturation is improving. But for severe ones, we could use sildenafil. Yeah, we use nitric oxide, which is a pulmonary vasodilator, can as well be used to treat the patient pulmonary hypertension. In some rare cases, we could also use, preload reducers like furosemide, spironolactone. Yeah. So, okay, somebody said, what of something like a 2 millimeter membranous VSD coexisting? Then the diagnosis is something else, because a lot of emphasis, there should be no additional shunt, right? There should be no additional shunt. So if we find a VSD coexisting, then look at the right ventricular outflow tract very well, because there could be a right ventricular outflow tract obstruction. Yeah, so there could be right ventricular. So when a VSD is coexisting in this kind of case, it's not persistent pulmonary hypertension of the newborn. Yeah, so this is the end of the road. So we have the quiz. We really appreciate our audience for staying with us for this long. So, but let's hear and score ourselves whether we've been making sense. So quiz time.
Okay, so this is the last question for today, and it's, which of the following is the strongest risk factor associated with development of transient tachypnea of the newborn? The first is cesarean birth of a 38-week gestation infant. Second is hypothermia, maternal edema, maternal preeclampsia, and the last is small for gestational age.
Yeah, so let's get options. Let's get answers rolling into the Q&A. Let's get answers rolling. Wow, we have a plethora of answers already. We are excited with the answers that are flowing in. Yes, so transient tachypnea of the newborn, which is retained fetal lung syndrome, occurs commonly in 10 infants that have had cesarean section that is usually elective. Hypothermia can cause respiratory distress quite well, but that will be corrected as soon as the temperature is normalized, as soon as the neutral environment is gotten. Maternal edema is not there. It's not there. Maternal preeclampsia, not really. Rather, even babies whose mother have hypertension have better lung. They've been stressed, so they face less stress. Small for gestational age babies can have their own for their own reasons. Yeah, respiratory distress syndrome. Yeah. Thanks. So all the answers here are correct. So thank you all. We really appreciate. We'll end this presentation today by saying we sincerely appreciate your participatory listenership, because it was like we're teaching each other, and it was a great time discussing respiratory distress in newborn babies. And I'm sure we've been able to say what respiratory distress is. We've been able to give differentiation between cardiovascular, pulmonary causes. And I am sure we are able to identify patterns of imaging, chest X-ray patterns for common pulmonary and cardiac causes of respiratory distress in newborn. Thank you all. We really, really appreciate. So once finally the slide, this is Limi Children's Hospital. You can locate us easily on Google Map. We are at number 39 Ademola Adetokunbo Crescent in Wuse 2. So this is the end of the presentation today. Just to let you know that as part of Limi Hospital continuous medical education for development of capacity in Nigeria, the cardio care will also be making a presentation in the next few weeks, so stay tuned. There would be an Instagram live today on blood pressure, on hypertension by our cardiology team today, later in the day at about 6 p.m. So stay tuned for that at that time. Now, on the 16th of next month, Limi Children's Hospital will be making another webinar now by our pediatric neurology team. You will be, I'm sure you like it when you join. Thank you. We really, really appreciate your, so we'll send the slides. Thank you all and good night.
The Limi Children's Hospital is a multi-specialty children hospital with advanced specialty in neonatology, pediatric cardiology, neurology, hematology, nephrology, and vaccination. We provide a variety of clinicians to help deliver the best possible care. Our physicians and nurses have been recognized by a number of independent organizations for overall excellence. We offer consulting services, regular nursery care, premature birth care, and treatment of babies with mild to severe illnesses across our different integrated facilities. Our neonatal intensive care units are well equipped with infant warmers, incubators, phototherapy, monitors, ventilators, and oxygen hood or nasal cannula. As a baby's and family's first pediatric caregiver, our neonatologists often begin their work by providing prenatal consultation to women experiencing preterm labor, carrying multiple babies, or following the finding of a possible congenital malformation that may require special preparation for the birth and coordination of treatment services for the infant. For more information, log on to www.limechildren.org.